Thank you, Naini. Ladies and gentlemen, good afternoon. I know this is one of the most challenging sessions in any conference. Keeping you alive in the post-lunch session, I will try to do my level best. So we're going to talk about recurrent abdominal pain in children. So GF Still was a pediatrician about a century and a bit ago who was working in UK. He has said this, I quote, "I know of no symptom which can be more obscure in its causation than colic abdominal pain in children." I wonder, after a century and a bit away, whether we have come closer to this, we are still living there, or whether we have gone at least beyond that. Let's see, ladies and gentlemen, what is there. Sorry. So in this lecture, we will discuss what causes chronic abdominal symptoms, epidemiology and risk factors, pathophysiology, novel concepts of bowel damage and psychological damage, what's new in evaluation, and futuristic view of management. So we all know this, causes of recurrent abdominal pain in children. It's so well known, and from gastrointestinal diseases to liver diseases to urinary tract to gynecological problems to a lot of other things can cause chronic abdominal symptoms in children. So the list goes on actually. So, but we examined this phenomenon at one point in our research, and we noted that in Sri Lanka, urinary tract infections, urinary calculi, GORD, and antral gastritis or duodenitis and amoebiasis are the common causes of abdominal pain in children. This is after studying about 120 children. So only 6 we could find a reasonable cause after extensive investigation. So ladies and gentlemen, the question is what is happening with the rest? What do they have? To me, they have functional abdominal pain disorders. So this is what most children with chronic abdominal pain are suffering from. So there are 4 types, and they are including functional dyspepsia, irritable bowel syndrome, abdominal migraine, and functional abdominal pain, otherwise not specified. So in addition, so let's look at what is happening with regards to the epidemiology. So this is the global epidemiological map which we drew in this year, actually 2025, and it shows, you can see Sri Lanka, we have mapped that, and totally in this meta-analysis, we found 11.7% of children in the world is suffering from one form of a functional abdominal pain disorder. So 11.7% has chronic abdominal pain in children. So this is the data from Sri Lanka, wherever you live. We did all these studies in various parts of the country, including Anuradhapura. So in Gampaha district, it's about younger children have lower prevalence, and in Western Province it is 13.6, Ampare 11.9, even at Anuradhapura 9.2. The island-wide prevalence in Sri Lanka is about 12.5. So what are the risk factors for this enigmatic disorder? So we have several risk factors that has been identified. Increasing neonatal gastric suction, we would never think something like that cause abdominal pain in children, but you see increased neonatal gastric suction can lead to abdominal pain association, and separation from mother in the neonatal period is a known risk factor, and child born to mother with gestational diabetes, pregnancy-induced hypertension is known to cause problems. Admission to a special care baby unit itself can be a challenging thing to a neonate and later found to have abdominal pain, and other events like repairing of umbilical hernia, surgery for pyloric stenosis are also associated with abdominal pain. In addition, some of our research has found home and school related stressful event, something very similar, simple like separation from the best friend, frequent punishment at school, failure in academic exams, and admitted to hospital for another illness still can cause some form of abdominal pain. And high stress scores and high worrying scores are also associated with functional abdominal pain disorders. This study we conducted a few years ago, about 10 years ago, find out the association between functional abdominal pain and child abuse. You can see physical abuse, emotional abuse and sexual abuse all are associated with development of functional abdominal pain later in life. And effect on microbiome. So let's look at microbiome, and this is the blue color thing called healthy microbiome. When we have right genetics, when we are getting right breastfeeding, because breastfeeding can transfer the microbiome from mother to the child, and then we have right diet and we living with animal, we can have healthy microbiome. Now what happened after a while, we take antibiotics, we take junk food, and then microbiome grows and it has a pathological orientation with all these risk factors. So they are pathologically oriented microbiome which develop with time, and now we only need a small break in the intestinal epithelial cells. So when we have the break, these microbiome, they locate into the subcellular space and start reaction with all these things, including releasing cytokines and various stimulating various pathways, including TNF. All these things lead to subcellular level of inflammation, and that can lead to a development of functional abdominal pain. So effect on brain. So brain has prefrontal cortex, anterior cingulate cortex, and amygdala and periaqueductal gray. These are the areas of the brain that deals with visceral sensations in the body. So when we have things like stress, abuse, early life events, all these things also lead to pathological orientation of the brain. So you can understand how complex that can be, but still these are the well-known risk factors that has been associated with functional abdominal pain disorders. So what causes bowel damage? Actually this is a very novel concept. So low-grade mucosal inflammation, I showed you how it comes, altered microbiome, altered brain circuits, and motility abnormalities, and sensitization of continuous firing of gut-brain axis and hypothalamus-pituitary axis. All these things lead to some form of a bowel damage, which lead to persistence of this abdominal pain. So how are we going to diagnose these things? You don't have to have any rocket science to diagnose functional abdominal. It's the easiest thing to do. So we take history and examination and look for red flag features, and if the red flag features are positive, you need investigations, and sometimes you can find organic disorders like inflammatory bowel disease or gastritis or duodenitis or GORD, something. So if all these things are negative, they have functional gastrointestinal disorders actually. It's so simple. So there are 4 types, as I said. So if they are associated with changing in bowel habits, they are having IBS. If they have postprandial fullness, early satiety, epigastric pain, they have functional dyspepsia. They have paroxysmal pain associated with these things, abdominal migraine. If they don't have anything, only the pain, they have functional abdominal pain. So it's a very important clinical diagnosis, and it doesn't need a lot of investigation. So what are the basic investigation if you want to do something? ASR include basic blood counts, inflammatory markers, and urine microscopy and stool microscopy. This would do in the majority. And fecal calprotectin. Fecal calprotectin is an interesting investigation nowadays coming up. So it's a calcium containing antimicrobial protein complex and released during acute and chronic inflammation in the gut. I think one speaker before me talk about fecal calprotectin, he was absolutely right. So it's about 40 microgram per gram of stool is considered as normal, which is very consistent with functional abdominal pain disorders, because they don't, although they have submucosal inflammation, these things never manifest. So the normal fecal calprotectin is such an important thing if you want to do. But in Sri Lanka, the problem is we get positive or negative calprotectin, we don't get a value. So I generally don't do it because it doesn't give me any added advantage of diagnosing. So what do we do? Do we need an upper GI endoscopy? So this is a cartoon drawn by one of my friends about endoscopy. So we can do endoscopy, right? And this is all what we can say. So we can say there are few cells and all these things in various parts of the gastrointestinal tract, but we are not going to sort out the child. So gastrointestinal endoscopy need to be very reserved in very selective cases of abdominal pain. So it doesn't help you, right? So motility studies, our group have been focusing on this area for a while, and we found gastric emptying rate and enteral motility index, which can be done with using a simple ultrasound scanner, has a great value in confirming in difficult cases. It's anybody who want to do that can be done. It's done at Ragama Medical Faculty Gastrointestinal Laboratory. So all these children can have abnormal gastric emptying rates and abnormal motility indexes. So what can we do with these children? What can we do in 2026 and beyond? So look at this cartoon, right? So I suggest their gut and brain are both on fire because of all these pathological features that I have described to you. They are having enormous amount of suffering. So this is what happens. So it's our duty as physicians, pediatricians, whoever, to extinguish this fire and help them in some way to get on with their lives. So how can we do this? Again, this is where our clinical sense and things that we can do matters a lot. So we evaluate these children. We can diagnose functional abdominal pain disorder in the second part. So then we have to decide where the predominant pathology is. As I said, it's a multifactorial disorder which involves various parts, brain, gut, somewhere. So there are central predominant mechanisms, like if you find abuse, stress, anxiety, depression, early life event. So they have a different profile. If you have mixed central and peripheral abuse, dysmotility, stress, abnormal microbiome, post-infectious abdominal pain, depression, they have different. So if you have peripheral mechanisms like involvement of the intestine in various ways, like post-infectious, dysmotility, abnormal microbiome, dietary triggers, immune-mediated, they need to be treated very differently. So what about pharmacological management? People have done a lot of research on pharmacological management of functional abdominal pain, and most of them are inconclusive. And the most important trial which was conducted and published in 2025 found mebarin, which we commonly use in children with functional abdominal pain, is no more better than a placebo. So most of them, our research in 2015 found domperidone is effective in treating children with functional abdominal pain. So, but majority of these pharmacological interventions are inconclusive. These things are still under evaluation. So this is what I can say after reading all these pharmacological management interventions are not very successful in controlling symptoms. So then we have central directed non-pharmacological modalities, right? So let's look at these things like, this is cognitive behavioral therapy. Various people have done this. This meta-analysis very clearly shows that cognitive behavioral therapy has some place in managing children with abdominal pain. Then effective yoga and hypnotherapy. So yoga has no effect. Only 2 research has conducted in that. Meta-analysis shows not much of an effect. And again, hypnotherapy also touches the line, so hardly any effect. So dietary interventions, people use fiber supplementation for functional abdominal pain, increasing fiber. Again, it has no very useful, it's not a very useful intervention for children with functional abdominal pain disorders. So these are something that we use always. Probiotic as a therapeutic modality, this came Cochrane database intervention that in 2023. We have lactobacillus reuteri, not much of effect, and lactobacillus rhamnosus GG, again doubtful, and bifidobacterium lactis, not much. So basically probiotics also had nothing much to do with as a treatment modality. So this is what we do. We have a way of handling these children, so explanation, we continue on this ladder, right? We give drugs, we try to do this, we try to do hypnotherapy, alternative medicine, we try various things. But ladies and gentlemen, while we are trying this cycle of interventions without much of an effect, this is what happened to the child. So they get ball damage, psychological consequences, healthcare expenditure, poor education, family issues, and finally ended up having very poor quality of life. So don't you think we need a paradigm shift? So how can we help these children? I think as I said in my chart, so if somebody is having IBS-C, for an example, with CNS effect, we probably would suggest to use a motility agent and PEG and probiotic, and to address the psychological effect, we use something called hypnotherapy. So then we gradually calm down and stop the drugs when they resolve their symptoms. Very similarly, if somebody has IBS, diarrhea predominant, we can use local effective antibiotic like rifaximin, probiotic, and central effect. To mitigate central effect, we can use cognitive behavior therapy, then we come down on the tank. So this aggressive treatment can help children so that they have less suffering and they have no consequences in this. This is the proposed model for me to move forward with children with functional abdominal pain. So in summarizing what we found, so FIPD is a common problem across the world, and risk factors are also equally common, and altered microbiome, visceral and central hypersensitivity play a potential role in the pathogenesis, and simple clinical evaluation provides a diagnosis. Uncontrolled symptoms lead to bowel and psychological damage. Early aggressive treatment to control symptoms is such an important thing in their management. I love Anuradhapura, and this, whenever I get a break, if Damita Chandradas is here, who knows, I always come and stay around one of these places for a while to relax myself. So I'm very thankful for the organizing committee for inviting me to be here and to be a part of this wonderful conference, and all the very best for your future endeavors. Thank you very much.